Hi friends, welcome to World Explorer. Like, comment and subscribe my YouTube channel. Today's topic is SpO2 monitoring. All the content taken from the WHO Pulse Oximetry Training Manual 2011. The topic of today is SpO2 monitoring. SpO2 monitoring is a non-invasive technique and it measures the amount of oxygenated hemoglobin and also the pulse rate. Oxygen is life for human beings. All body parts need oxygen. Brain and heart is very sensitive to the lack of oxygen. Even if 5 to 10 minutes of cut off oxygen supply to the brain lead to brain death, so we should be very careful while providing oxygen to the patients. Hypoxia is nothing but shortage of oxygen to the body parts, which is usually represented with the symptoms of cyanosis or cyanosis to be treated urgent basis. And this is the basics of oxygen transport in the human body. Hemoglobin is the iron containing protein which is carrying oxygen to the blood, and in the blood it is taking oxygen to the body parts, and in the lungs we can see oxygen mixing with hemoglobin in the pulmonary capillaries, where the blood is flowing through pulmonary capillaries, and we can see oxygen hemoglobin. Then this oxygen hemoglobin is getting transferred to all the body parts with the help of heart by the blood. So the gas exchange will take place at the alveolar, hemoglobin which is carrying, and heart is pumping the blood to the body. So what is SpO2 is representing? It is nothing but displaying a functional oxygen saturation. How we are going to see the SpO2 monitoring? It is how like this. When there is a light which is passing through the sensor and then it passes through the tissue, it converts electric signal, that is called as a photodetector. And there is something called SpO2 module which processes this electric signal and displays the waveform and external values for SpO2 and PR in a monitor. Now let us see some basic calculation of how oxygen and hemoglobin is related. 1 gram of hemoglobin approximately carries 1.34 ml of oxygen. So if you see 12 grams per dl hemoglobin is present in a patient, it may carry approximately 800 ml of oxygen, because we are having 5,000 ml of blood, and per 100 ml it carries only 16 ml of oxygen. So if there is 15 grams per dl, you can see 20 ml of oxygen carried by 100 ml of blood, so it will be approximately 1000 ml of oxygen. Now anemic patients are the one who is experiencing severe hypoxia, because we can see the hemoglobin levels are 2, 3, etc., and it's very difficult to manage, so they may need blood transfusion if patient is anemic. Cyanosis is the bluish discoloration of the skin. The SpO2 probe has a red light which is passing through the finger, and it is again displayed in the monitor as a SpO2 and pulse rate. We can see these probes are of different types: hinged probes and hair probes. Hinged probes are easily damaged because this can be broken easily. So in order to avoid the breakage of probes, ensure that it is not falling on a floor or patient is not going to pull it away, etc. And hair probes are very lightweight and can be used for the children. And we can see here these are the electric thing which we are going to connect to the monitor, and this should be taken very carefully, because we have to adjust in such a manner so that these things will not get damaged. If this is going to damage, automatically we cannot see the SpO2 reading. Probe may not function properly, so check the probe by keeping one finger if you are in a doubt. So next thing is alarms. Alarms SpO2, if it is 90%, less than 90%, we can see the alarm. If there is no pulse, alarms may be there. If there is decreased pulse rate or increased pulse rate also, we can see the alarms. Now these are the main causes for low pulse alarm: bradycardia, halothermic anesthesia, severe hypoxia. And if it is high pulse alarm, it is because of light anesthesia or inadequate pain relief. So next, what to do if there is hypoxia? A, B, C, D, E. Airway, breathing, circulation, drugs and equipment. If there is airway obstruction, ensure that obstruction is cleared. We know that Heimlich maneuver, where we are giving abdominal thrust and removing the obstruction. If there is aspiration, we have to remove the aspiration with help of suctioning. And if there is a breathing problem like bronchospasm, treat the bronchospasm, pneumothorax. Or if it is because of anesthesia, we can decrease the dose of anesthesia. If it is circulation problems, hypovolemia, replace the fluid. We can see very clearly if fluid is getting administered, patient may improve the SpO2. And if there is heart failure, treat with the drugs. If drugs is causing the hypoxia, sometimes anesthesia, muscle relaxants also may cause hypoxia. And sometimes apart from this, equipment problems like disconnection of breathing circuit, battery failure, faulty probes, sometimes central oxygen supply may not be there, so we have to go for oxygen cylinder. Even if it is not there, then we can go for the ambu bag methods, etc. What can we do if there is decreased SpO2? 100% oxygen administration. This can be done even before anesthesia. We are doing technique called bagging, or ET intubation also we do the bagging. Bagging means we are giving 100% oxygen with the help of ambu bag, enoughly oxygenate the patient, because this oxygen can stay for 3 minutes in a body. By the time we intubate the patient may get enough oxygen to the body parts. And if there is obstruction of airway, clear the airway by suctioning. Assess ABCD. To summarize, if SpO2 less than 94%, it is a symptom of hypoxia. Check for the probe, reposition the probe. Again, if it is normal, then it's okay. If still the problem is persisting, go for ABCDE, airway, breathing, circulation, drugs and equipment. So this is ABC method is seen in earlier days, but now it is CAB in new guidelines: circulation, airway and breathing. So first we will go for circulation. Check for heart rate, BP, ECG, pulse, etc. Check for carotid pulse. If there is any issue, start the CPR immediately, that is with the compressions. Okay, if there is circulation is good, then go for airway problems. Then see if the chin lift, jaw thrust method, or reposition the laryngo mask airway. If there is ET tube, reposition can be done. Sometimes accidental ET extubation can be done in the patients of ICU. Or if there is laryngospasm, treat the laryngospasm. And if it is a breathing problem, see the tidal volumes are fixed in a right manner in ventilator or not. Respiratory rate is decreasing, auscultate both the lungs. If it is bronchospasm, treat with the bronchodilators, and pneumothorax, chest drain may be done. And then drugs, opioids, sedatives, we can decrease the dose. Equipment, oxygen cylinder, oxygen problem, if there is, then we have to transition for the ambu bag. Thank you. If you like my channel, subscribe to my channel World Explorer.